Good morning, everyone, and welcome to our webinar this morning, which I am proud to deliver to you. My name is Lorraine Chantrill. I'm chair of the AGITG. I'd like to start by acknowledging the traditional owners of the countries on which we are meeting today. I come from Dharawal country of the Wadi Wadi people in the Illawarra of New South Wales, and I'd like to pay my respects to all elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples here on our meeting today. I would also like to acknowledge the Maori as Tangata Whenua of Aotearoa, New Zealand, and as treaty partners with the Crown as agreed in Te Tiriti o Waitangi. It's my great pleasure to introduce two exciting panelists that we have for you today. I'd like to introduce Dr. Hui-Li Wong. Now, Dr. Wong is a medical oncologist who has expertise in GI cancers. She's involved in clinical and translational research in colorectal and pancreatic cancers. And her research interest lies in understanding the biology of cancer and how this affects the treatment and a disease course for individual patients. It sounds like personalised medicine, Dr. Wong. I'd also like to introduce Associate Professor Vicky Whitehall. Associate Professor Vicky Whitehall has researched the molecular basis of colorectal cancer for the past 20 years. She's contributed key conceptual advances to understanding the evolution of colorectal polyp subtypes to clinically relevant groups of colorectal cancers. So again, very important work, and I thank Professor Whitehall very much for being with us this morning. So our topic for you today is unlocking the mysteries of artificial intelligence and big data in GI cancer treatment. And when I heard this title, I was quite fearful. I thought, oh my goodness, this is something that I'm not really very good at. But I think it's also something we really need to talk about, especially in the context of cancer trials in GI cancers. So I think we'd all acknowledge that clinical trials in GI cancers are absolutely essential, but we acknowledge that they actually involve relatively small numbers of patients. And there's actually a lot of other people we need to know about who aren't on our clinical trials. And there might be ways in which we can access data sets about those patients, and we would call those real world patients. And there might be Medicare data sets or hospital record data sets that we can access. And Dr. Wong and Dr. Whitehall have got some really good ideas about how we can access those real world data sets to help us understand the trajectory of cancer patients, and maybe we can inform our clinical trials better. So we're going to start with a little bit of introduction about this field, because Dr. Wong and Professor Whitehall are going to be teaching all of us about this, and then we'll have a little bit of a discussion, a panel discussion amongst the three of us. But then most importantly, I'd really like to open the forum out to all of you so that you can ask questions through the Q&A tab there at the bottom of your screen. So I think Dr. Wong is going to speak first, and then Professor Whitehall, to just give you a bit of a flavour for what we're going to be talking about today. Thanks, Dr. Wong.
Thanks so much, Lorraine, for the introduction. And can I just say how excited I am that we are talking about this, because I feel like I'm such a data nerd, and I think all of us are. But like you said, you know, the terms big data and AI have been more and more widely used. I think we're all a lot more familiar with them, but then they're still quite big concepts, I think, and I'm really glad that we have the opportunity to talk about this. And so I thought it might be nice to start with what big data generally means. And in a very broad term, it basically is just a collection of these massive amounts of information from a variety of sources and for large groups of patients. And I think we've probably seen a big advance in big data research because also of the advances in technology and digital technology. And if we think about, you know, like the electronic medical record, for example, it probably wasn't that long ago that we were still, you know, as clinicians writing all of our notes on paper. And in some places, we still are doing that. But more and more places adopting electronic medical records now. And, we're thinking, well, how do we tap into all of this information that's being captured? But that's really just one very small part of what big data is. There's all this stuff about, pharmacy information, and pharmacies capturing prescription data. There's all of the scans that patients do, not just the reports, but the actual images themselves. Things within the lab, like the actual pathology results or biopsy results. Vicky's going to talk a bit more about the genetics of tumors, but all of this really rich sources of information. And then more and more now, we are also starting to think about, well, how do we tap into, when we think about patient-focused outcomes, how do we get that information a bit more, in terms of patients reporting their own outcomes rather than what doctors are recording patients are telling us, what patients are actually saying themselves. And so that's, a whole part of it as well. So there's all these huge and I guess disparate sources of data. And so now our big challenge is, well, how do we bring all of this data together? How do we use AI or, like advanced computing to try and analyze all of this data? So a lot of my work and interest is in what you mentioned, Lorraine, about real world data and in particular registries, I guess. So, with all of this data, I guess it's not really structured in a way. So all of this is just captured as, day-to-day practice with patients coming in to be seen. And I'm involved in a few cancer registries where what we try to do is to capture data that's actually going to be useful for research. So we know in advance what things are important to know about that particular patient and their cancer, what particular treatments and outcomes we want to find out. And we try and define that ahead of time and to think about a way of capturing all of this information so that we can actually use it in a research way. And I might get Brett to advance to the next slide so that I can share why this is so important to me. And I really like this picture. And Lorraine alluded to the fact that, RCT here is basically our traditional randomized trials. And these are hugely important because, these are studies that are done in a very controlled way. And this is a way we know that treatments are robustly tested. And we absolutely need to continue doing our trials. But you can see that, beyond trials, there's this whole bunch of patients who are not included in trials. I think it's something like only about 5% of patients participate in cancer trials. And there's many reasons for that. And so there are all these patients who are being treated in what we call real world practice that we don't have any information about. And so I think that, this is why it's important to me that we are capturing information on potentially underserved populations. And in the next slide, so I think, oh, sorry, Brett, thanks so much. So this really is just a graphical form, I guess, of by way of introduction about what potential uses we might have for big data and AI to improve outcomes for our patients with, and this is, for colorectal cancer. And so the insight circle tells us about, what the types of information that are particularly important are. So clinical data might be, what's happening with the patient and their underlying health issues or their medications. And then we've got information now on the tumor itself, like pathology, what scans look like, the genomics. And then on the outside circle, that tells us about, how can we apply all of these information to different parts of the cancer journey. And that, includes going from screening to trying to estimate a person's prognosis, trying to decide on what treatments might be better individualized for that person. And I probably should have gone the other way, sorry. So screening and actually diagnosing cancers as well. So that's mainly my overview, I guess, or introduction into the topic. And I think Vicky was gonna take over from here and go a bit more into the genomics part.
Thank you. Yes, next slide, please, Brett. So here I've just taken a few images to try to give an overall impression of what I refer to as big data when I'm analysing things in the lab. On the left-hand side of your screen here, we have an image that represents I think it's about 150 colorectal cancers. So every column is a single patient, and acrossways we have genes. Now there's 27,000 genes in the human body in every single cell, and these genes are turned on or turned off in different ways to give rise to the certain cell type of the body. And in cancer, this gets dysregulated. So we want to find out what's different in cancers that might be causing this. These indications can also give us an idea of how a patient is responding to treatment. And of course, 27,000 genes is far too many for us to observe with the human eye. So we're able to use computer algorithms or programs to cluster the data in ways that make it easier for us to see. So you can see in this green and red image here, where red is genes turned on to a very high level and green is the genes turned off to a very low level. You can see that there's two fairly obvious clusters here of cancers. And we've been able to delve more into this, and looking at these two different clusters, we've actually found that these types of cancers do behave differently in the clinic, and they've given us a lot of ideas about the certain patients in each cluster may respond differently to different therapies. So we're pursuing that now. And on the right-hand side here, I've just shown another way of viewing data. There's all sorts of ways to view this big data in a way that kind of collapses it so you're more able to see patterns with the human eye. And you can see here that this data has been analysed in a number of dimensions and colour-coded to show that there's 3 subgroups of cancers, and that might represent 3 types of responses to therapy, or 3 types of clinical behaviour or biological behaviour of the different cancers. Now, we can do what's called unsupervised cluster analysis, and that's when we just throw all the data into the computer, and that's what we've done here in these 2 images, and the computer processes it and brings us the patterns that make most sense. We also can do what's called supervised analysis, and that's where we say, for example, these patients responded very well to this therapy, these patients did not respond well to this therapy. What's different between the 2 groups? And that's a way of answering a very specific question with a large amount of data. So next slide, please, Brett. This is an example of something we're doing using artificial intelligence in pathology. This is actually a picture of a colorectal cancer. Here, can you see my pointer? Anyway, on the left, there's a picture of a cancer, and we've actually stained this with something that lights the tumour up red. And if you go to the next image along, you can see that the computer has actually colour-coded red or green, and red is the tumour cells. So what we can do is show the computer enough cancers that it starts to recognise on its own which are the red and which are the green. And in that way, it can identify the tumour cells. We can then further partition the tumour cells based on whatever additional features we want. And in the far right hand, you can see a much spottier image. And this is where we're highlighting different types of immune cells based on various markers we've stained this cancer with. So we trained the computer with a number of cancer samples, and every time we told it which immune cell was which. And then after that, we could sit back and run additional samples through the computer. And based on our initial training, it was able to tell us for the subsequent samples which cell is which. And this is a very powerful way of analysing data and can become very accurate. And the important thing to remember is that the more samples you have at the start that you can use for training, the more accurate you're going to have your classification in the end. And we further use this data from many hundreds of cancers to try to collapse it into a way that's visual for the human eye. And you can see that we've identified 6 different overall patterns below. On the left, it's quite green. On the right, it's quite multicolored. And the red cells are actually the immune cells. And what we've been able to identify is, for example, this one on the right, it has a lot of immune cells. These patients had a very good prognosis compared to, say, the ones on the left that had very few immune cells. So with this big data, we're able to start with a lot of patients and a lot of data and collapse it down using very specific algorithms to make it in a way that we're able to understand and that correlates with meaningful clinical outcomes. Next slide, please, Brett. And this is my last slide, and this is what I'm most excited about and think really is the point of it all that a lot of us are trying to get to, and that's personalised medicine. So you can see here on the left, the patients are all indicated to be the same colour. We're not really understanding what's different between their cancers, and that means that we don't know which therapy to give them. But by integrating pathology data, genomic data, clinical data, we can more and more understand the various drivers of the different cancer subtypes. And you can see that if we're able to integrate all these massive data sets, we can then get a really good understanding of the different types of cancers that different patients have. And then we can, and you can see with the therapy here on the right-hand side, we can then allocate certain therapy based on the features of that particular patient. So that was my main quick overview. So thank you very much.
Thank you so much, both of you, for that introduction to this amazing field. So tell us, Associate Professor Whitehall, tell us how you're using it are you using what you've been able to train the computer to do in the real world yet, or is this some time off? And how far away are we from using this in the clinic, do you think?
I think it's very incremental. So we're already starting to use some things, but there's a lot of potential to use a lot more. For example, we know a particular marker that predicts response to a certain therapy. That's just one, and that's used in the clinic right now. But it's my hope that in 5, 10, 15 years, we'll be able to profile the entire genome and predict drugs for every single patient that's going to have efficacy.
That sounds like it would take a long time, or do you think with this machine learning it'll be quick for each patient?
I think it's speeding up very rapidly. I think there is still a bit of a knowledge gap in terms of what is able to be delivered in the clinic. We can look at a lot of things in the research setting that currently is not possible to do in the clinic because the instrumentation or expertise isn't there. But gradually it is improving and expanding, and even in the last 5 to 10 years, I've seen massive changes in the clinic and what's able to be delivered. So I have a lot of hope that things will continue to develop rapidly.
Thank you. So we've heard about how this technology can be applied to people who already have cancer to maybe improve their treatment, make their treatment more personalised. But Dr. Wong, can you think of any other applications for this technology outside of biomarker-driven treatments?
Yeah, you know, and I guess I'm speaking a bit to some of the work that's being done overseas and not necessarily being done within our group, because we very much are still focused on patients who've already been diagnosed. But, you know, if we think about where we might be able to make the biggest impacts in terms of patient outcomes, it'll be around, you know, screening or prevention or diagnosis, you know, trying to catch these patients early. And, you know, there is work that's being done to try and use big data, like say in imaging, like say, for example, you know, patients having screening colonoscopies, you know, to try and look at the images from those to see whether or not you can pick up which polyps are more aggressive looking, or pick up polyps that are missed, or even trying to use that information, not just the imaging information, but also the, you know, trying to use the machine or the computer learning to learn how to read a colonoscopy report. And there's some work going towards, you know, feeding that back to the clinician doing the colonoscopies to say, you know, hey, are these according, like, does everyone have like the same quality colonoscopies, and trying to improve practice straight away. So, you know, there's, I think, a lot of excitement, I think, about how using big data might be helpful, you know, even earlier on before a patient gets diagnosed.
Thank you. And even perhaps for prevention, I remember seeing a poster at ASCO one year about dietary characteristics of different people, and now we're hearing the term microbiome is often heard around. Do you think that we could use big data analysis to look at different microbiomes, different dietary intakes, and their risk for developing polyps or colorectal cancer? Professor Whitehall, do you think we could do that?
Yes, absolutely. I think we all have quite a different microbiome, and that's another massive growth area in terms of research and even delivery of therapies. So definitely, there's a lot to learn about the microbiome, and we do know that patients with certain flora are more predisposed to certain types of cancers and could even benefit from different dietary interventions.
I suppose, though, dietary interventions or dietary recording requires people themselves to input data. Do you know of any examples of public data portals where people can put data like that in? Do any other countries have that kind of facility? Dr. Wong, do you know of any?
Yeah, so not off the top of my head right now, but there's certainly a lot of work going into, trying to design surveys and things for patients to be able to capture their data. I think that a lot of the dietary data that we've had have been from large prospective studies where they followed people over a long period of time. And it's always very challenging because trying to capture this data relies a lot on recall or memory. I think the hope is that, as more people are using smartphones or mobile tools or apps, that, perhaps that might be a way to integrate that a bit more. There's certainly a lot of work going into using apps or mobile devices to capture things like exercise. I think that's a lot easier because people have their phones on them, and to look at how active people are. So that's a bit easier because you can capture that information without a person entering that in. Whereas I think, with diet, you still do require that being entered in by a patient.
Yeah, the exercise piece is a really important one, and we have seen some research in clinical trials demonstrating that exercise can prevent recurrence of cancer. I think we've seen that proven in breast cancer and to a certain extent in colorectal cancer as well. But you're right, getting a wider, as we've discussed, not just that small number of people in the trial, but a much wider population to study would be a really great thing to do. Do you think it's a very expensive thing to do this sort of research, or is it actually cheaper than doing a clinical trial? Professor Whitehall, what do you think?
I think it is very expensive. I think there's usually cost associated per patient or per data point. So to get hold of enough data to have really meaningful outcomes can be quite expensive. And that's one of the bottlenecks at the moment. If we could do a lot more, if we had a lot more funding.
Yeah, and what about the ethical implications? And I'll be interested to hear what our public who are listening to this webinar today, what they think. But do you think that we need to get consent from each individual patient whose data is being used in this way? For example, Professor Whitehall, you presented some pathology slides. I'm assuming that you would have had to have obtained patient consent to use those pathology slides, but should we have like an opt-out form of consent where anyone who has treatment through Medicare funded services sort of consents to have their de-identified data used in this way for the greater good? Or do you think that we need to keep getting consent from individual patients?
I think it's a very important point, and I'm keen if anyone wants to comment on this as well, to hear what everyone else thinks. Personally, I would like the opt-out system because I think it's really important to involve as many people as possible, and also to guard against disparity in health delivery. I think if you start including people or not including people for various reasons, then you can get some bias in the data and the outcomes are less meaningful. However, we do also have to be very mindful of people's preferences and make sure that they are happy to be involved. In the studies that are conducted in my lab, everything is de-identified, but there is a possibility of re-identification by certain individuals in certain ways. So we're very careful with patient data and patient identification. We would never, of course, publish any of that data, but we do need to be able to eventually link back to the clinical outcome, and then we can have more meaningful outcomes in our findings.
Yeah, thank you. Thank you. There are some questions coming through from the audience today, and one of them is about the fact that commercial institutions are already obtaining our data. I know every time I go to Woolworths, if I use my Woolworths card, I think they're getting a lot of data from me, which I've presumably consented to because I've signed up for the card. Can we learn from that corporate approach, and can we do that kind of data collection? We'd learn lots about people by what they bought at Woolworths. Dr. Wong, do you want to answer that?
I think I think I would echo Vicky's thoughts here around you know, I'm trying to think of how best to answer this question, I suppose, and I think in a way that comment came from, you know, a lot of us are giving out our data without really thinking about it. I mean, I definitely click yes at the bottom without reading all of the, you know, all of the disclaimers. And I think we probably do it because the outcome is worth more to us than what we think, you know, and that we all have some element of trust that our data is going to be preserved in some way. And ultimately, we want to be able to shop at Woolies, and we want the convenience. I think that as researchers and clinicians, we do have to be very careful to make sure that we are protecting the privacy of our patients. But I completely agree with Vicky that if we force everyone who's already, you know, sick or coming in and overwhelmed with their cancer diagnosis, and then if you add in another piece of paper to say, we want you to sign this consent form so that we can also use your data and your, you know, tissue samples for research, that's not going to reach everyone. And, you know, there'll be some people who are just too sick to consent at the time, and then these are the people who are the most vulnerable that you do need to study. There is, you know, there are ways, I guess, under the ethical guidelines that for some research studies that are considered to be very low risk, where the data that you use is completely de-identified and, you know, it is not going to be prejudicial in any way, that and you know, it is for the greater good, then we should go ahead. But then, you know, when it comes to tissue samples, it gets very challenging. I think one of the things that we want to try and work on is to make it more of a cultural thing that I'd like to see, that everyone expects, you know, that if you're going to hospital and you're getting treatment, then of course you're going to have your data being used. Kind of like, I'm going to Woolies, I'm using the app. Sure, they're going to collect all of this data, and just have that as an expectation. But I do think we also need to preserve and make sure that, you know, we are taking privacy seriously.
Thank you. I think you articulated that very well. Sorry, go ahead.
To interrupt. In my couple of decades of frequently consenting patients for studies where we are collecting tissue, my findings have been, anecdotally, everyone I've interviewed has been delighted to participate in the study, and we try very much to not overwhelm them with pages and pages of information. But I feel like in such a challenging time as in the middle of a cancer diagnosis, it can actually be very gratifying for the patients to be able to contribute something that may lead to some good down the track. So overwhelmingly, I mean, I don't think I've ever had a patient say no of thousands of patients. So I think that's something to keep in mind as well.
I agree with that, and I think that perhaps we should be looking to governments for legislation for, you know, low impact on personal patients but big impacts on population with use of data where it could be justified. I think we've all heard scientific stories of pathology blocks being put in the bin, which is an enormous waste both to the people who that tissue belonged to, but also to the scientific community and to the country as a whole. So I do think that we've got some way to go in terms of fixing that pathway to better research outcomes without any significant impact on individuals, significant negative impact on individuals. I'll come to some other questions that have come from the floor. So look, there's a big promise, I think, to leverage the super responders to targeted therapies to further optimize or personalize treatments. So do you think you could do that? So I think the question is, we take those outliers who do really, really well and work out how and why, and then apply that in terms of personalizing the medicine. Is that what your work does, Dr. Wong? Is that what you're doing?
Yeah, I guess my work is mainly more along looking at the clinical data and looking for some patterns. And maybe the best way to illustrate this in a broader term is that, like say in bowel cancer, we know now, or like in metastatic bowel cancer, we know now that patients with tumors in their right side don't do as well as patients who have tumors in their left side. And some of those observations actually came not so much from trials initially, but from big data sets and, trying to look for patterns in who did better and who did worse. And then after that, that got taken on to looking at patients within the trials and kind of forced the trials to look back at their own data to say, oh, well, do we see this like sort of different outcomes and different responses to drugs based on whether or not patients have a right or a left-sided tumor? And so, and then we've seen some of that data pan out. And then now, to the step of trying to understand why that might be the case. Is there something genetically or genomically about those tumors? And now, there's the group or lab that I'm working in now has designed a trial to look at, patients with right-sided tumors for these markers, like these, they're called sort of ligands or these receptors called epiregulin and apiregulin, and sort of looking at the expression within right-sided tumors, and then trying to explore, what their outcomes are if you give them a particular treatment. So that's, to me, I guess, like a bit of a story for how we can come from looking at big data or real world data to start to ask questions, use trials, support trials, and help us to design our trial questions as well.
Thank you. It's really interesting, isn't it? The right versus the left side of colon cancer. That idea came quite late, actually. So the idea that right-sided bowel cancers might be biologically different to left-sided ones was only thought of maybe 10, 12 years ago. And then we had to go back and have a look at all of our trial data and then unpick to see whether we actually had the data there to say whether they were right or left-sided primaries. So it's very interesting that sometimes very simple things can be very important biologically. So we have a question about the cause of cancer, and I'll read the question out and I'll answer it a bit, and then I'll defer to Professor Whitehall to answer it more. So the question is, what causes cancer? What causes colorectal cancer, and why is it more common as people age? And it's rare that children get bowel cancer. The way I answer this question when I'm asked in the clinic is that I explain that as we age, our ability to check mutations that happen within our bowel becomes impaired with age, and we're just not as efficient at finding those changes and mopping them up with our immune system. And so that's why, by and large, bowel cancer incidence does increase with age. But there also are some conditions where polyps occur in the bowel that predispose patients to bowel cancer. And I know Professor Whitehall has worked for a long time on the transition from polyps to cancer. So you might be able to answer this a little bit more. What causes bowel cancer and how does it progress?
I think I have to agree with you that it is a bit of random bad luck in many cases, and you need to accumulate the alterations that work together to make a cancer. And as we age particularly, but in all cells, every day or so, particularly in the bowel, they replicate very quickly. So there's quite a high turnover in the bowel, which is probably why we have a high incidence of bowel cancer. Because every time a cell divides and replicates itself, there is a chance of an error being made. Sometimes that error leads to the death of the cell, and that's a good thing because the mutation doesn't stay. Sometimes it doesn't lead to the death of the cell, so the mutation stays, and if in the next division you get another mutation on top of that, it might be just enough to make a polyp. You actually need quite a few mutations to make a cancer, so there's not that great a risk. But we have recently, and this is something that my lab has really focused on, been looking at a different type of changing the genome or the genes, and it's something called methylation. It's not an actual mutation of the gene, so it's not a permanent change, but it is something that can turn genes on or off, the activity of the genes. And what we've realized is that as we age, we accumulate this methylation of the genes, and gradually genes get turned off. And the reason I'm really excited about finding out about this is because this is something that can be altered by interventions. And we've shown that aspirin supplementation, various other dietary supplementations can reverse these age-related methylation changes. We've also shown that some particular mutations work with these methylation changes to make a cancer. So we've looked at cells from young patients and cells from older patients, and then mutated a gene on top of that. And the young patients, when we mutated the gene, nothing happened. The mutation caused nothing to happen in those cells. But the older cells, when we mutated the very same gene, that they had these underlying methylation changes and they progressed to cancer quite quickly. So it's more about how everything works together and getting enough of these changes to make a cancer.
So it sounds like you might have found the secret to aging and long life. So all we have to do is stop the cells in the bowel aging. Is that right?
I think that would be helpful.
So aspirin's a very good example. Aspirin's a very good example of an intervention that has been studied with big data. I don't know which one of you want to take this question, but I think we have seen big data show us that aspirin is preventative for a number of cancers. How far are we away from putting aspirin in the drinking water, do you think? Dr. Wong, how far away are we from doing that?
I think, with the data, with any kind of data, I guess, and observations that you see from these big data sets. And I guess one of the challenges around big data is that we want to know that what we're seeing is true and that it's not been affected by bias. And so, with all of the results, it then tends to need to be tested in a prospective, very controlled fashion. And I think we're definitely getting there very soon. Like there are, trials that have been run, that are continuing to be run, and I think we'll continue to see that data come out. And it's nice to think about how we can also use big data to run these trials quickly, I suppose. To try and get answers as fast as we can.
Mm. So I'll do a plug for AGITG, who actually were part of the ASCOLT study, which was a study of using aspirin as secondary prevention for people who have sporadic bowel cancers, not for people who had Lynch syndrome or inherited bowel cancers, but for sporadic bowel cancers. That was a clinical trial done in collaboration with several international sites led by Singapore. We have yet to see the results. I think we'll wait a long time for the results as it's a prevention study. So that kind of study takes a long time and costs a lot of money to do. And we're very proud to have been part of it, and I would like to be part of more of those kinds of studies if we can achieve the sort of government funding that's required for that. But I hope that we can show that it would save a lot of money in the long run if we're able to show that a simple intervention with a very cheap substance like aspirin might prevent cancer. So thank you. Another question we have is, how specific are these approaches and techniques to cancer? Could there be a move towards data specialization in multiple fields, or should we have like data specialists within our cancer center? Do you, Dr. Wong, do you already have data specialists in your cancer center, and are there people busily doing big data when you're sitting in the clinic helping you? How does it work?
Yeah, that's a great question. I think that there is definitely a lot of, being a data specialist, I think is increasing more and more. And I think what we are seeing is that collaborations between, cancer clinicians and cancer researchers and I guess data people, and that's not a good term for them, but you kind of do need that collaboration, because I'm never going to understand enough about AI and methods and data analysis to be able to do any of that. But then, our data specialists would certainly benefit from knowing our perspective on what things are important to control for, so that that when we're looking at data, that we understand all the potential biases that go into it. I'm pretty lucky, working at Peter Mac, and within the Parkville precinct, that we've got a health services research department, and so we have people who work with us who are data specialists, not so much in the clinic, I guess, but working very much in the background on research projects that hopefully will come closer and closer to the clinic. So I would say it's very much a collaboration, much like with Vicky's work and us. We collaborate with scientists in the lab. We're also collaborating with data specialists as well.
Yeah, thank you. Another question from the floor is, are there good examples in medicine where high-level pattern recognition through AI has actually produced a better outcome? I think, Professor Whitehall, maybe you can speak to pathology that might be able to do this. Maybe that's done in routine practice in pathology now using computer recognition. And how can we make sure that that's correct? How can we make sure that the quality is checked of that kind of computational analysis?
I don't know if that is standard yet. That there are probably little examples where obviously computers are being used and that has been implemented, but these use of these big pattern recognitions, I'm not aware that that's been implemented in the clinic yet. And mostly I think that's because of the lack of available expertise as well as equipment for doing this. I think increasingly we will see it implemented. And in terms of accuracy, I think that the key really is to have enough patients at the start contributing their samples so that we can train these algorithms to be incredibly accurate. And I think just something we touched on before that's also very important is that the computer can even recognize patterns that we can't see in the clinic. And what might not be appreciated is, for example, in terms of colorectal polyps, there's actually many, many different types. There's probably 10 different types of colorectal polyps. And the clinician, when they get the report back from the pathologist, reads this, and there's a very detailed process for saying, okay, this patient has this polyp, therefore you need to come back for a colonoscopy in 3 years. Or if you have a higher risk polyp, you come back in 1 year, or maybe not for 10 years. So that's all based on the human pathologist recognizing patterns. But now that we're developing more AI or artificial intelligence approaches, we're starting to recognize patterns that aren't necessarily intuitive and aren't being recognized by the pathologist, but do correlate with certain outcomes and certain pathologies. So yeah, I think increasingly we will be able to access these technologies.
Thank you. That sounds like a very hopeful for the future. A question for Dr. Wong. The discussion so far has concentrated mainly on colorectal cancer. How do you see this technology applying to other cancers? The audience member is asking about pancreatic cancer in particular. They're very interested in early diagnosis, particularly in younger people with pancreas cancer.
Yeah, so I guess, and Lorraine, you might be able to speak to this as well, in your area of expertise. I'm not sure if you wanted to take that question first before I give my thoughts.
So we have in Australia had a familial pancreatic cancer registry where we have tried to obtain data from families that have pancreatic cancer as an inherited disease, particularly in patients with BRCA1 or BRCA2 mutations. Unfortunately, as we've alluded to, that represents quite a small fraction of the pancreatic cancer population, but we have been able to learn quite a lot from that population to try and inform us for the patients that develop sporadic disease. But the reality is that at the moment, today in 2022, we have no early diagnostic test for pancreatic cancer. And other than families with a strong family history, we really cannot pick out people at risk of pancreas cancer, particularly young people at risk of pancreas cancer, aside from those people who have chronic medical conditions like chronic pancreatitis. We do see a link between diabetes and pancreas cancer. That link is not very well understood. We know the two things often happen at a similar time, and we have just started a campaign to alert primary general practitioners that if people develop diabetes in absence of the usual signs and symptoms, obesity and so on, if they develop diabetes without those syndrome X signs, that should be raising alarm bells to image the pancreatic gland with ultrasound. But other than that, we really haven't come very far. But Dr. Wong, you might have some ideas about what sort of data sets we could look at in the pancreas cancer population to see if we can do better there.
Yeah, I think I agree with everything that you're saying, Lorraine. And, I think some of, I don't have that much to add, but I guess some of my ideas would be a bit more maybe out there and thinking about what might happen if we did have access to large data sets. And, you mentioned one of those key things around that link between diabetes and how that's often recognized at GP practices. And so, if we had the ability to link up to GP records and, what patients present with, and even have, these flags and recognizing patterns, like say, not just the diabetes, but other things that are happening in terms of a constellation of patient symptoms. And if you can kind of design an algorithm that's there and built in to sort of flag to a GP so that, it kind of takes away, it's kind of like decision support tools. It takes away from them having to remember that maybe we need to do this, that might be a way to improve outcomes. But, it absolutely depends on having the capacity to both access and tap into those data sets.
So that's a really cool idea. So we could link blood glucose levels at pathology tests with BMI. And if there's a low BMI and a high blood glucose level, that should ring an alarm bell and alert the GP to do something about that maybe. That would be one step forward. Might make a lot of work for people though. Pancreas cancer is still an uncommon, not rare, but uncommon disease. Yeah, very hard to do in practice, but I think we need to think outside the square, like you said. So I'm going to save the most difficult question for last, which I'm going to put to Professor Whitehall. This is the hard one. This is a $64,000 question. So we talked a little bit about the flora of the gut, the microbiome, but in fact, it's influenced by the environment, and that's not very well controlled. And also, what about the relationship with the brain? So how we think and how we are emotionally may actually influence our microbiome, both immunologically and otherwise. So how do you think big data can analyze that?
Oh my goodness. Absolutely, that is a big question. It's important. All these things interact. Definitely the microbiome can influence the brain and even the incidence of depression and those sort of diseases. So I don't know, I think it's a very big question. Big data can help us understand that better, probably can help us balance the microbiome better. But I think that there remains massive challenges in implementation. So even when we can discover, for example, this particular bacteria or this particular dietary intervention would be helpful, getting that information to the patient and helping them to implement that in their everyday life is I guess, ultimately the challenge.
Thank you. And with that most difficult question, which I thank the audience for providing that difficult question, I'd like to thank you all for attending today's webinar and for supporting GI cancer and the AGITG. We're very proud of the work that we do, and we're very proud to have you along with us for the ride. If you would like to donate to our organisation, there's a link there. I'd like to say a very special thanks to Dr. Hui Lee Wong and Associate Professor Vicky Whitehall for joining us today and giving us their very precious time to educate us about big data and artificial intelligence. Thank you all very much. Thank you very much to the audience for your interaction and for your attention. I'd wish you all a very good day. Thank you.